Hi.
Hello.
Hi, Heather. Good morning. And good morning, everyone. Look at this
Good
wonderful
morning.
bunch of mentees. My gosh.
Apologies, Allie, for being delayed to get started for you to practice. But it looks like our connection is good.
Good.
I can hear you well.
Okay, great. Great. Hey, everyone. Thank you all for being here. This is really exciting. I'm imagining Heather will get us started in just a moment. Thanks for doing this, Heather.
Yes, thank you for being here. I'm excited to hear your talk.
Well, I hope we have a discussion because we've got a lot of experts and expertise and experience and all kinds of good stuff going on. So
Yes, yeah. I think we have a lot of folks who would be ready for a healthy discussion. I'm just gonna wait for maybe one more minute, let people get a chance to. And
thanks for that, Sharon, and good to see you today too, Sharon. Well, at least you're square.
Oh, just I passed it along to Kim Newswad too. So
yes, I see. Yeah, and I see Kim is here as well.
Perfect.
Fantastic.
Perfect.
Yeah, representing you are.
Well, I guess I can go ahead and introduce you, Allie, but you might not need much of an introduction.
I definitely do.
Okay, well, we know that you joined in 2006 as part of the Miami group and working as an independent trainer and consultant since 2007, as well as coding and coaching for healthcare professionals across many different evaluation tools. You have service to many MINT committees and TNTs over the years, and currently serving on the board in the professional skill development grouping. And joining the conversation today from San Francisco, California, with your two hardy dachshunds. I love it.
Yeah.
So hoping to discuss our observations together about coaching healthcare professionals and enhancing those motivational interviewing skills for all. So I'm excited to be a part of the conversation. I'm looking forward to it.
Thank you. Thanks, Heather, and glad to see so many friendly minty faces today and see so many joining. And I have to tell you that when Heather reached out to see if I would come and initiate a discussion together today, I thought, yeah, well, but I'm not even a healthcare professional. And so this is sort of the ironic thing about my whole Mint life has been being constantly invited to provide coaching and coding and skill development feedback to healthcare professionals, and I'm not one. And it has been the most fabulous gift from my perspective, because I always have to have the beginner's mind, because I have an ignorant mind. I can't bring anything related substantively to what the person is going to bring. But what I can bring is an openness and an idea, maybe some options about enhancing what people really want to do well. And the reason that they're seeking out coding and coaching, the reason that they're seeking out MI training, that they're looking for evaluation and observation. And that is a wonderful position that I've been able to enjoy for a long time now. So here I am, the non-expert, non-physician coach, but that really staying in my lane and making sure that I'm helping people use ideas that make sense to them with their specific expertise and content has kept me humble for many years now. But I just noticing, I mean, we have so much experience in this room and so many different ideas and probably a lot of different perspectives about coding and coaching and helping people enhance their MI skill development. But what I thought I might do is just offer a couple of observations that I, sort of hard-earned, observations over the years. Well earned, not necessarily hard because it's always joyful, but certainly well-earned observations. But in a couple of categories, and just see what you think. What helps those that you serve? What has helped you as a healthcare professional? Just curious. So the main observation in terms of categories that I would like to introduce, see what you think, is sustained talk, what to do with that. And early on, I think when people are learning MI, they have one of two primary responses to the appearance of sustained talk in a conversation. And one is to, well-intended, jump in and fix it. Sort of emphasize the importance of the change, emphasize that the person should be confident, minimize the difficulty, just whatever, just jump in and fix it. And we know how well that goes. The second common response that I hear in health professionals is to comfort it. So they score off the charts on empathy, and their sustained talk, they're just digging in the quicksand. And maybe they learned MI before we understood more of the role of sustained talk and change talk, and that's fine. So they thought they were supposed to comfort it, or they thought they were supposed to explore it until it disappeared. And of course it doesn't, the more we do it. That's what we know. So those are those two things. And we know there's also maybe a third, or maybe there are more than three, but I think there's a third response, which is to embrace the relationship, the reluctance, as well as embrace change at the same time, because people are always standing in one spot and their eyes are looking somewhere else. So the well-intended clinician, we're going to, I think, try to help them give an understanding of where the person stands, but also embrace where their eyes are looking. Because that's the great thing about human beings, right? Is that we're never happy with the way things are. There's always something we want. There's always something we wish for. There's always something we're sick of in the current situation. And that's great material, I think. And I think it is the case that busy healthcare providers haven't thought of it in that way yet. And that can often be profitable for them to really make that one simple shift. But it requires people to listen in a different way, right? All right, so what do you all think? How do you help healthcare professionals? What observations do you have with folks around sustained talk? And what are some things that you help people do?
Allie, I'm Steve Cole. For those of you who don't know me, I'm a physician, and I always like listening to you speak, Allie, because you've got such a nice way of bringing important things clear. I'm scribbling away as you talked, and I think you had a lot of pearls there. Unless it bothers people, could you just do it again in a 2 or 3 minutes? 'Cause
Yeah.
I really like those three things, and particularly that pearl about the third way you might approach things. I just want to capture that.
Well, I'm curious, thank you, Stephen, are there others that the third way kind of resonates with, or maybe there are more than three?
Well, tell me what the first one is again, because it's
Yeah,
about the expert
yeah.
thing, right?
Fix it. Yeah, fix it.
Oh, fix it.
Yeah,
Okay.
fix it, make it better, make it go away.
Got it. Thanks.
Yeah. And we know that of course, is problematic. Comfort it,
Got it.
and then just embrace both the reluctance and change at the same time, because both things are always inside of us. And that's that idea really of human beings always standing in one place and looking somewhere else. And if we can, where we're standing, I think, is so much more concrete and specific, and we're so familiar with it. We can talk about the nuts and bolts of exactly where we're standing. We're less good about talking about this wispy thing that's out there, but our eyes are always seeking for something that may also be seeking for us. But this, like, what is it? What is it that the person is wistful, wishes for, optimistic for, tired of things? What is that? What is that thing? And to reflect that piece helps people create a path from where they are to where they really want to go. 'Cause the path isn't there yet until we speak to it, right? What other thoughts? I see Carol's
You
Carol's
read my
brain
mind.
turning mightily.
Yeah, you know, the third one, thanks, Ellie. The third one that you mentioned, I was thinking of a variation of that, actually another piece of that, because a lot of the healthcare professionals I train are trained to go after barrier language. And I hear them asking things like, you know, tell me why, you know, what would get in the way for you, or why is this difficult? And honestly, you can work with that. And I think the
Sure.
framework that you provided of embracing the reluctance and the change at the same time is really helpful, because as a trainer, I feel like I've been trying to maybe do a hard steer away from that. Like, don't ask about barriers. Don't go
Yeah.
fishing for that.
Nothing to see. Don't look over there. Look over here. Yeah.
And the way that you described this third category, I think the barrier seeking, talking about barriers could fit really nicely into
Yeah.
that. And I
Sure.
think that would be a way to bridge
Mm.
a learner's mindset, because they're like, what? How come shouldn't I ask about barriers? And so then I say, well, yeah, yes, and, you know, the yes, and, you
Yeah,
know, ask about your ideas. Well, what are your ideas of getting around those barriers? You know, what have you thought of? What has worked for you? You know, that kind of stuff.
Makes
And
sense.
so that's what I was thinking. Thanks for.
Yeah, fantastic. Yeah, because it's only a barrier if I want to be somewhere else. You know, why is the person, and I don't mean this in a dismissive way, but why is the person spending so much time focused on that hurdle? They know their hurdles very well, and probably have already thought of or would welcome or shining the light around it. Yeah. I read this Rogers quote, of course, you know, the other day, and this is kind of, and he said many things, but one thing he said was, in my early professional years, I was only asking the question, how can I treat or change or cure this person? Now, I would phrase the question in this way. How can I provide a relationship which this person may use for their own personal growth? And I think a lot of times our healthcare professionals are so incredibly busy that it feels like there's not time to develop that climate from which people can spring. And the quick fix seems like such a great idea, you know, but I only have 5 minutes. So being mindful too of these time pressures that people feel, and facing, you know, helping people face situations where they have multiple areas of suffering. You know, how do we help our folks make the best use of their time in providing the best climate from which the person can spring? And I like that, Carol, about this idea of, yes, there is this and it sounds like you're really familiar with that and have probably thought of other things and, you know, some options already for yourself. And it sounds like you want to be on the other side. That might be a good use of time.
Before we move on, Allie, could you read that Rogers quote again?
Sure. In my early professional years, I was asking the question, how can I treat or change or cure this person? Now I would phrase the question in this way. How can I provide a relationship which this person may use for their own personal growth? What were you thinking, Cheryl?
You have me thinking, and I appreciate that so much. In the work I do with trauma, how I've been thinking about this is that this, taking both sides of it, is our acceptance of that human being. It is that radical acceptance that they are okay just the way they are. And what I've noticed is that when they feel safe in that, they have more courage and energy to try something new.
Mhm. Yeah, thank you, Cheryl. That makes perfect sense.
Allie, can I be a little more concrete?
Yeah. Hi,
No-
Chip.
Hey, how are you, Allie? So I guess as I'm listening to this, I'm thinking about kind of, engaging, focusing, evoking, planning. And I think I've found, in working with patients and with practices, I do a lot more of that now. Um, it, and I hope this kind of goes along with what we're talking about. But if you in the engaging process, if you do talk about those barriers, and there they are, let's talk about them, and you're in that process of building that engagement, building the relationship, and building trust, that when you kind of get closer to that, evoking, moving into the planning phase, then those things have already been dealt with. And so at that point, I think they're much more open to moving along the path toward where hopefully we both want them to go. Does that make sense?
It does, and I kind of wonder when we're thinking, and it does to others. I see a lot of nods and smiles of recognition there. It also feels like to me, thinking about focusing the agenda. I mean, it may be that there's this umbrella of things that that are collected underneath values that are maybe even upstream, things that we can help people with at an upstream level. It may not just be helping our kid be more adherent with their inhaler, but maybe it's an upstream thing, like advocating to the landlord to change the filters in the building. There are a lot of things that we can do that help people tap into their own empowerment and provide sort of bigger solutions that are related to maybe values and strengths and skills and things that may very well be a barrier. And yet reducing some of the barriers together may be something that we do even with focusing of the different challenges that you've already mentioned. Where would we get started? Which of these could we reduce a little bit that would give you the kind of relief? Maybe there's a larger solution we can look at together. But it's this idea, I think, of partnering and looking at and I guess, and working together maybe to lower some of those hurdles to make things feel more possible or connected some way under a larger umbrella, I think, as opposed to an overwhelming task list, or there's so many problems here and we need to address all of them. I can see that these things are related for you. And it's kind of like a bowling ball thing. Like, where can we roll the ball down the lane that knocks down the most pins? Just a thought about that. But thanks for bringing that up, Chip. Heidi, what were you thinking?
You're muted, Heidi. Gotta unmute.
Okay, how's now?
Thanks.
Perfect.
Got it.
Okay. As people have talked in this conversation, I keep thinking of my biggest outlier MI experience. I was doing MI in a really small rural practice. The nurse would bring me names of people who she thought might benefit from an MI kind of conversation. And she came in one day and she said, "This guy won't even talk to you. He won't talk to you. He's so sick. He has severe diabetes. His blood sugar is always getting worse." She said, "We don't know what to do. Call him." And I called and I talked to his wife first. And she had more of what I did more often with MI, of what worked for her, what didn't work for her, what drove her bananas when people would call her up from a doctor's office and tell her what to do. And then she handed it to her husband. And the nurse had said he probably won't talk. And he didn't. All he said was, "Oh." And I thought, how do I not get anything that I would normally do would be getting ahead of someone who just says, "Oh." So I just described, I'm someone who has conversations with people where they get to think about what's most important to them and their health. And I said, I can't I won't start this conversation without you because it's about you and it's your choice. Oh, like he said, oh, probably 5 or 6 times. And that was it. And I thought, well, you can't win them all. And then 2 weeks later, I talked to his wife and she said, what did you do to my husband? I said, what? She said, you lit a fire under my husband. He had 6 doctors he had been needing to see for like 6 months or a year. He got off the phone with you. He scheduled the appointments. He's been to 2 of them already. What did you do to him? And then 3 months later, the nurse ran in and said, his A1C went down for the first time in the history of ever. So it was just an outlier, but so powerful that really he made his own decision.
You're muted now, Allie.
That's a beautiful story, Heidi. Thank you. A lot of nods and smiles there too.
I definitely think like it's such a power of choice. Like I feel like what you were sharing was, where you go with this is up to you. And, I think that that's something that's really important in our interactions with folks as well, right? Like what you decide to do is up to you. We see the barriers, we see the strengths, where you want to be, but like, and this is my role. And if you'd like to engage, that's great.
Absolutely. Yeah, thank you, Heather. And so another idea might be around how to so how we walk in the room, the exam room or wherever, but how do we walk in the room and invite the person's perspective and not just be a deficit detective? And I think when I think about some healthcare professionals, and this is not a judgment about anybody or anything or any profession, but dermatologists are in particular really good at walking in, maybe even with a magnifier on, and if you got something here, it's all about that, and they probably couldn't tell you what color your eyes were or anything about it. But they're very zoomed in on on the thing. And of course, people suffer greatly, and it makes sense they would like relief from that suffering. But when we're too focused on the problem and can't see the person beyond the presenting problem, as we assume it is, that's kind of problematic. And so if you were to ask any provider, what do you do? Well, I'm a dermatologist. Oh, what is a dermatologist? Oh, it's a skin doctor. I think the definition we're hoping to hear is, I'm a doctor for people with skin, right? And this shift that maybe people begin to take that, for example, one dermatologist that I was working with, shifted to a typical day strategy to learn a little bit about the things that may or may not have changed, that may or may not have contributed to a rash or something like this. And also would routinely say things to a patient like, how long have you been suffering like this? Tell me more about it. This idea that people really felt heard, and that their perspective felt invited to come forward. And that ended up making, and kind of looking at people in the eye and trying to see the whole person and not just the rash on the arm. It's just another shift that I've seen people make, and it has worked out well for them. Mindy's talking about, from from fix it to comfort it, right? Yeah, and then of course, right, and then it's very reinforcing. Yeah. So to come back to Mindy's point here, finally the person, if they're comforted, feels heard, and then the clinician is reinforced for having done that.
Well,
Exactly.
so I'm was wondering, and I hope I heard everything, because I've been trying to unpack these 3 polls or pearls that you shared on reacting to sustained talk. And I should share, but one of the reason I feel persistent on this, that on today's Monday, on Wednesday, a group of us are working with 30, 40 consultation liaison psychiatrists at their annual meeting on teaching about health behavior change. And I'm looking for sort of nuggets of pearls. So when you say expert, fix it, the response to sustain talk, fix it and comfort it. And the third pass, which I'm lacking, but I'd like to just get all your ideas and yours, Ali, about embrace it, just unpacking it and making it simple, because doctors want things really simple and clear. So embrace sounds a lot like comfort, but it's more than that, isn't it? So what I think I liked what you started to say was embracing is embodying the comfort, but looking for something else about where the person is looking. And in my mind, and if I see your head shaking, which is, I'm glad I got that then. I've gotten enthusiastic lately about storytelling. So lots of the other pieces that I think I heard many of you say was about what opens up after the comfort and looking for that. But if we're looking for, I'm thinking of the Leonard Cohen song also, there's a crack in everything. There's a crack in everything, that's where the light begins. So I'm thinking, well, if it's a story that I'm inviting, if I can comfort and then tell me the story of, or I'm interested in the story about, whatever it is, smoking. In the workshop, we're going to deal with smoking cessation issues, but I'm interested in hearing more about smoking. I think, is that what you're talking about? I'm talking about how to define embrace. If we're going to use that, what are you embracing and how's that different from comfort?
Yeah, I guess embracing the complex situation that we find ourselves in as human beings, that we're quite familiar with the status quo. And it may be a burden that we, that we're ennobled by carrying. It may never have been heard before. We're very familiar with it. Doing anything different might be scary. And yet there's something about it that we're not happy with. And there's something else that we would like. If we see ourselves 6 months from now, do I envision being in this much pain? Do I envision being more active? What is it that I hope for that has not yet landed?
So
and that's the embrace.
So
And
embracing is comforting plus searching, I guess, or comforting plus
embracing both the reluctance around change and the comfort and dissatisfactions and sufferings of the status quo, as well as where I might like to be. I think, I don't know. And Mindy, you're absolutely right that highly empathic response, and yet that's half the picture, right? To be able to hear for someone to be able to hear our hopes and our dreams and our optimism and our strengths and our values, who we might be beyond who we find ourselves in this moment. I don't know. It's a thought though. What do you think, Mindy?
Well, I'm thinking a lot of things. This is really helpful so far. Thanks, Ali. To my question, I think sometimes the positive reinforcement is more powerful than what I can articulate. And I find myself wanting to sort of convince them to find that middle ground faster than they're wanting to, or their experience leads them to that. So again, letting go of the training process the same way we let clients and patients lead their own change process. Yeah, I was just curious if the group or if you had ideas to better articulate, besides just bringing the evidence about what we know about sustain talk, and the more we generate, the more we lose opportunities to generate change talk, and it can harden someone's position in not changing the status quo. So I think I'm trying to reconcile that everyone will have their natural way of sort of oscillating between position 1, fix it, position 2, comfort it, and then finding that what really is, the most, I think, compassionate and useful state, which is embracing the reluctance along with embracing the potential for change. So that holding both, right?
And I see Melody's got something to to chime in with too. So I'm grateful for that. What do you think, Melody?
Yeah, I just really appreciate this conversation. And one of the things, I train nurses, physicians, behavioral health clinicians at a healthcare facility in Wisconsin. And what I found is that they really do go towards what are the barriers. And so one of the things that I emphasize, I don't know if this is helpful for you all or not, but it's the first thing we see when we open a chart is the problem list. And MI is not about searching for the problems. It is about searching for what's right with people and what strengths they have, and evoking and drawing out from them what is within, in order that they can lead a healthy life if that's what they choose to. So so I really, and some of our patients are, their problem lists are as long as their arms, right? They are. And so I really emphasize, let's find out what's right with the patient. And I appreciate that honoring autonomy that someone had sent earlier, and the conversation about embracing. To me, that embracing is really staying embedded in that MI spirit, right, of acceptance, because I think that's a huge thing for patients as well. And so I realize my contribution here is all over the map, but I would like to say, to soften, sustain, talk, and guide the conversation towards change, what the people that I train are finding useful, and I do as well in conversations, is that double-sided reflection, really empathizing with them initially and then gently guiding them towards change and highlighting any change talk that they may have had. So those are just my thoughts. I kind of went all over the map, but that's my 2 cents.
Yeah, thank you for that, Melody. And it seems like, you know, people show up to a clinic, they keep the appointment that they made, they answer the phone if the provider calls. You know, what is it inside the person that's answering the call? What is it inside the person that took 10 buses to get across town? They got 3 kids fed and dressed and to daycare so that they could go to an appointment. You know, what is it that made, and yes, yes, to feel heard, and certainly to feel accepted and have their autonomy supported. And Carol's both and right. And we also know about the long-term alliance that if we only were to comfort, and the person does not begin to move towards changes, the provider begins to become disenchanted with a relationship. Like, these people want to come in here and tell me about, well, if we've reinforced that, yes, there is that level of acceptance, and it should be a place that people can talk about their greatest concerns, or we can provide the thing that people most need in that moment. I'm just thinking about a woman who had lived on the streets most of her life, and she came in finally to seek some therapy services. And she promptly, when she came into the treatment room, would fall asleep. And it was, oh, well, she's in denial. You know, of course, one set of theories is she's in denial. She doesn't want to talk about her issues. You know, she wants to avoid her issues. Well, no, the first place she had ever felt comfortable enough to have both eyes closed was in that room. So what did she need most? To give her a pillow, you know? I mean, just providing people what they need most in that moment. And then, you know, and then we, you know, and we can go from there. Kimberly, what were you thinking?
Gosh, I feel like these conversations have been going so many wonderful directions that I may have lost my train of thought a little bit. But one of the things that really struck me when you were going all of the information earlier, Allie, and listening to you, Melody, as well, is when we have patients coming in with these problem lists that are just this long, really coming from a value-based approach is where I've found my training and my interactions with my patients to be most meaningful, because we only have 15, 20 minutes of time as clinicians, but when we can link as many of what they're in here, if I understand why you're here and what's important to you, that gives me the best use of my time over 20 minutes. And I feel like it naturally builds that high empathy and that partnership. It just opens up so many opportunities to just create validation, connection, that everything is just fruitful after that, and allows us to continue that and statement that Carol mentioned. It allows us to look at barriers and link them to their values so that it's more easy for them to overcome. And then Mindy, just in thinking about how sometimes we do get stuck with that as clinicians, we're like, okay, they're really valuing our empathy. Now I'm stuck here. for me, I always ask myself, like, have I really served this patient? And when I only give empathy, I feel like, oh, you're right, Allie. I feel disenchanted. I haven't helped you see it all, or you haven't made all the links. So I feel like that is a nugget I've always passed on to people I work with. It's just when you leave, you feel great about the empathy because they've told you that, but in your clinician's heart, like, have you really put the spotlight on them and have they really benefited? Those are just some things that come to my mind in listening to all this great talk.
Thank you, Kim. I really appreciate that. And so I wonder if we could transition a moment to the expert trap, because I think this kind of feels like a natural segue to me here. And that, that more comes from the fix-it approach, but there is a lot of expertise that the healthcare provider has to share, or resources or things that could be helpful. And Kim, when you were talking about linking what's important to the person or the values or the strengths that we're hearing in people, it feels like if we can link our advice or resources to that greater because that the person has, like, I don't really have any business giving advice to anybody if I don't understand a little bit about the person beyond the problem, about their values and their strengths. And if I can't say, because independence is so important to you, I'm going to recommend that you try out one of these 3 things that could really help you reduce the risk of falls, age in place, feel a sense of balance and strength when you're moving around the house, right? My advice is going to be more valuable if I've got enough becauses developed in the relationship that I can connect that advice to. Otherwise, it's generic. It doesn't fit the person. And then the person says, who pointed you, expert in my life? Who invited you into my living room, and what are you doing moving around my furniture? So this idea of, connecting to the because, to the why and the can that's already inside of people. That would be one thought about coaching I would offer to the expert trap. Explore, partner, support autonomy, share resources that have a connection to what we've heard is already inside the person. Something I hear a lot in medical conversations, healthcare conversations, is the person being served comes up with some really great insight, some change that they're already making. They'll say, I feel better when I drink 8 glasses of water a day. Good, they'll say that, right? And then the provider says, yes, and we really recommend that you, and it's followed by this piece of education that clearly the person doesn't need in exactly that way, or without permission. So I wonder how do you all handle that when the person already has the insight, but the provider just can't stop and let me tell you exactly why you should be doing that. Discounting entirely the reflection or affirmation, or supporting the agency of the person to have come up with this great idea for themselves, or exploring what benefits they're noticing from hydration. What do you do with that one?
Gosh, Allie, I wonder if just jump in. I wonder if that's because so many of us are type A and we've gone through some sort of medical training and we still want to be the expert so bad when we have someone coming in. We feel like they just can't walk away without us giving some wisdom. And I wonder if this is what you all have done as well. But I find that sometimes we as the trainers get to allow our clinicians to say, you know what, it's okay to take the back seat for a moment. Sometimes I find that giving permissions, maybe especially to dietitians that can be type A like myself, having that permission to say, hey, it's okay just to say, wow, you know so much, or you care so much, and you've really seen positives from these behavior changes you've made, that is enough. That our extra 2 cents isn't required.
How did you come upon that? What benefits are you already noticing with this? How is it that you go about keeping track of all that? Just like something, explore their expertise a minute, right? Yeah. What were you thinking, Cheryl?
Well, I have a thing that I talk about, yes, that doesn't mean yes. and how risky that is in healthcare, that we just assume their yes is yes when we've moved quickly like that. And we may miss, you mentioned it, Allie, I think, that they may not want this piece of it, but there may be other things they'd be willing to do, and you're not going to have that opportunity to even know what those are. And I think that's the direction I usually go. Is it because you want them to do what you want, or is it that you want them to do the best they're able to do and will do?
Yeah, thank you, Cheryl. And really like connecting efforts to outcomes, supporting the personal agency that people are bringing to the capacity that they're bringing to each and every choice that they're making in their lives. Yeah. And that's the idea that if there are two bodies in the room, there should be two expert voices happening. Simply, and if there is one, better that it's not the provider, right? Better that it's the person, but ideally there are two, right? If there are two people, two voices.
Well,
Two expert voices.
a lot of times when I'm working with the residents, I try to get them to think of personal examples of going to the doctor, right? And I usually just use an example of myself, like when I go to the dentist and they ask me if I floss all the time. I want to say yes every day, but that might not be actually true. And I guess I think about this article I read too by, I think it was Ken Resnickow and obesity. Maybe it talked about the bobblehead effect. And so we talk about like how a lot of people might just come in and, just kind of go along with it. And so really, rather than getting to that point where you're giving a whole lot of advice and getting the bobblehead, taking a step back and thinking of that person in the room as the expert on themselves and having that strength, like you mentioned, to come up with their own ideas of what's next and what works for them.
Yeah, thanks for that, Heather. And Steve, you were thinking about stories. So one other story about the expert trap. Parker Palmer, the writer and philosopher, had occasion to place his mother-in-law in a skilled facility, very plush place though, and was told that if he were to pay just a little more each month, she would get to have all of this expertise and people circling around her and giving her all these resources and ideas and stuff. And she later expressed delight. Facility's nice, meals are great, really love this place. This is really wonderful. But you said there was that thing, if you pay a little more each month, they're going to give me all these resources and ideas and well, I'm kind of curious, would it be okay if we paid just a little less this month? Just, these people are they're really pests, and I know they mean well, but I don't want to hear it anymore. So I love that. Can we pay a little less this month? I also was working with a clinician the other day who she said that she had started working on extending the table to be big enough to share the agenda, right? She's got that down. And now her thing is, what she's working on is when she sees the person, she already sees the plan. And to stay in evoking towards the plan. That's her new goal for herself. I just love it when, people are doing coding and coaching and have such great goals for themselves. What are some goals that you've heard providers offer for their skill development? Yeah, Steve.
Well, I was just thinking about what I was going to say in the context of the question you just posed. I'm not sure it fits with what you were going to say. But let me, I don't know, can I make a little sidebar, defer your question to the group? Because that's so what I was thinking of is a little story with, I think, a lesson that I learned recently, 2-3 weeks ago. Rich Frankel, who's a very productive sociologist, and I have been working together on a variety of things. And we had this opportunity to present models of communication in the fields of multiple sclerosis. And we spoke to a bunch of doctors, and they were interested in the ideas we were presenting and very comfortable with it. And then we moved to a group of very skilled in the field of multiple sclerosis, mostly advanced practice nurses. And I got the kind of feeling, and I think it may have been true, that they had heard it all before. So some of the kind of core things, we were sort of expressing a lot of themes from MI, but other related fields. But there's one thing that I want to get to that they did embrace, and that might be relevant here. And I didn't realize, maybe it was a lesson for me that I might like to build on. It was about avoiding the expert role and the meaning of that. So we all know about avoiding the expert role and how important that is. But the reason I brought that up sort of at the end of the presentation is that the nurses, in their discussion of a lot of the concepts we were talking about, said, you know, you really have to work hard with some of these patients, and you have to enlist their families, and you have to find out what they're really thinking, and you have to find out how to motivate them best. And all of these things were true, and these were people with 20 or 30 years really powerful experience in the field, and they gave lots and lots of moving examples. But I said, you know, there's something, and there was bits and pieces of language of MI. But I said, there's one of the things that was so striking to me about MI and avoiding the expert role is that we try to work less hard. And when I learned MI, it was so much easier for me because I was able to ask patients not so much their expertise about excuse me, about the risks of smoking, but their expertise about how they might want to stop. So I could work a lot less hard. Well, I was, you know, pleased that although it was in the closing moments, a bunch of them were saying, oh, that's what we want to hear. I'm happy to work less hard. So that was just a lesson that I'm trying to remember in explaining the avoid the expert role, is that MI teaches us really how to work much less hard. It's much more fun as a clinician and less exhausting. We're not, and that's part of the concept of dancing rather than fighting. But I think maybe it doesn't get communicated in the power that we want it to, because everybody wants to work less hard.
Yeah, thank you for that. Absolutely. Work less hard. Work less hard and enjoy greater outcomes. Yeah, absolutely. And ideally, I think if we're hearing the values and strengths and the joy that is in people's voices, and we're providing some, you know, a menu of options that might connect to that level of joy. I mean, we're doing some good stuff. Just two other little tiny itty bitty things. And one is, if you have not had a chance to listen to it, I think it's something that I would advocate that you give a listen to. Sebastian and Glenn have that podcast, and some of you may be regular listeners to it. If you have not yet had a chance to listen to the episode featuring Claire Lane, if you have, and so some are like, yep, already got it. Yeah. If you have not already heard the episode with Claire Lane, highly recommend that. I think that what struck me over the whole arc of it was this idea that the way she practices and the way she describes the way she practices is this kindness with absolutely extraordinary skill and also holding focus. If you haven't had a chance to listen to that, I would certainly recommend that one. I was just really struck by it in particular. One last thing is, some providers may feel like this is really urgent and I've got to get through to these people, you know? And it's that, to me, it's this scare versus care kind of a thing going on. And what I sometimes hear is, listen, I've got to tell them you're going to die, you know, right? Or something maybe a little less dramatic than that. But, you know, it's like, well, yeah, aren't we all? But this further, this duty to warn, and it may be in a way that shocks and yeah, is particularly provocative. What do you do with that?
Ellie, I just recently was working with a primary care doctor who, the analogy she used, she was working with a patient who was a polysubstance user. And she said to me, if I don't help her, it's like there's a child standing in the middle of a street and there's a car coming. Like her writing reflects her fear of this person dying is so powerful that she feels like she has to, like you said, warn or save or do something. And so I would love some input on how to handle that. Again, coming from a really good place of care, but.
And also understanding that the unintended consequence of that is you don't know how it feels to be me, yeah. Right.
I wonder when you haven't asked people what they already know, because I worked in that field on inpatient rehab for 15 years as the director, and I never met a patient who didn't know what the risk was. I really didn't. And so it isn't a crisis in the moment, really. It's something they've been doing for a long time. Could they? Yes, they could have an outcome that's not so good, but have we really asked them about what matters most to them and understood that? Because I did meet some who that outcome was exactly what they would like to have happen. And I want to know that. I want to know where they're thinking, not what I'm thinking.
Yeah, thanks for that, Molly and Cheryl.
Along those lines, if I may, after hearing Steve Rolnick talk about a group of nurses that he was training in the UK who were so afraid to speak to these young moms about the value of infant formula versus just sticking something in a blender and giving it to them. Steve acknowledged that EPE was a skill that was not really upholded or emphasized enough within MI. And ever since then, I've pulled EPE instead of just an afterthought, but up to right there with OARS, right? OARS plus, ask, offer, ask, and really training them right up front that the value in asking permission, and specifically asking permission to speak assertively in situations where you need to, as a clinician or physician, share that information. And then also along the lines of what Cheryl had just said, tell me what you already know or would like to know, is how I phrase it, because I don't want anyone ever to feel like I'm quizzing them, right? When I'm seeing them for diabetes education or whatever it is. But really cultivating that skill of ask, offer, ask within the clinicians that I train, and now within leadership actually has been quite valuable. And it's not as complicated, right? It's just, hey, I'm knocking on your door. Is it okay if I come in? And I'm going to come in and we're going to have a conversation. I'm not going to head to every kitchen drawer you have and rearrange it, right? Or start throwing stuff out. So emphasizing that skill has been very helpful in my trainings and professionally.
Yeah, thanks for that, Melody. It's so helpful. This idea that, and I think as providers, as people who have a lot of expertise and developed it over many years, we just really have a much greater faith in the power of information, that my information is what's going to change this situation. And it's the person's response to what I have to say. It's what the person takes it and makes of it, right? That makes a difference, not information. There's plenty of information in the world and it just sits there. But unless people kind of roll up their sleeves and get their hands in it and make it their own somehow, it's a very little, hand somebody a pamphlet, right? and you're assuming that the pamphlet is this magical thing that changes behavior. And it isn't. It's their change talk to it that makes the difference. So thank you for that. Remember, if people are often get good at the explore and the offer with permission, and they forget the next explore. they forget the explore on the other side of the information, right? And that's what we want to get, I think, strengthened.
All right, I can't help myself. There's something that keeps bubbling up in my head about, I'm working with some muscular skeletal folks that are doing primary spine practitioner training where they teach psychology and health. And I'm reminded of something that my colleague in crisis and emergency services teaches me all the time, a lot of things, actually. I don't have to accept every invitation to an argument, which is awesome because I often do. And this notion of embracing people's pain. So I'm thinking about that, embrace the reluctance, and at the same time, that pain is a part of people. So these primary spine practitioners grapple with not just being an expert and the comfort and wanting to help comfort people's pain. How do you embrace their pain? It's a part of them. Some of them have had pain a good portion of their lives. And there's a part of them that not having pain, they don't even know what that would be like for them. So I don't know, I'm not going anywhere with this other than to say that that's bubbling up in my mind, and how uncomfortable I think some of the practitioners that I've worked with on the musculoskeletal either think it's, get them off of pain meds, get them out of pain, and or hope that they don't have to have back surgery because that's like the last ditch effort. And so there's a lot of assumptions made. And assumptions, one is that they truly want to get rid of pain right now, and why aren't they doing it, especially from a chronic perspective. But I don't know. I guess I wonder what you all think about leaning into. So my colleague would say, when you try to ease someone's pain, sometimes you rob them of the lesson that they want and need to learn for themselves, which we know is easy to conceive psychologically, perhaps more than physically. I don't know. That's at least my assumption.
Just, excuse me, just to weigh in on that. So I've been a physical therapist forever, and I'm also a health and wellness coach and a licensed social worker. So, because a lot of people's pain, as you know, comes from trauma. So we can do and do and do and never touch that. It's referring to what I just wrote in the chat earlier. If I can just, even not only the conversation and MI conversation, but also just letting the patient explore various postures, various activities, and even explore in a conversation what has helped them. If they've lived a life of bringing their body to a practitioner, so to empower them by having them start to be mindful about what's happening for them, and start to make a tiny change. That's been helpful for them. And it takes the MI conversation. I know I'm putting this blanket description. It helps them to not only explore that, but feel empowered to explore.
Thank you for that, Janet. And thank you, Amy, for your observations and good questions to leave in our heads too.
I want to thank you, Ellie, for being present with us today. and increasing our mindfulness about our MI skills and how we are training others. Appreciate that.
Thank you, Heather. Thanks for the invite, and thanks those of you for welcoming a non-healthcare professional to your gathering. You were very accepting and very kind, and I really appreciate the kinds of discussions that we get to have as these times together as mentees are just a great gift to me. Thank you. Thanks, everyone. Is this the end of our time? It's been really fun. Thank you, everyone.
Yeah.
Thanks, Allie. Thanks for the
Bye, y'all.
story.
The
Thank you so
conversation,
much.
Heather, the conversation
Ally.
is being recorded, I think, so it's available, it will be available.
Thank you, Allie, and everyone.
Thank you, everyone.
Thanks, Ally.
Thanks again. I really appreciate it.
Thank you. It was really fun.
Great.
Thanks, Heather.
Yeah. Take
All
care.
right. See you soon, I hope.
Okay. Sounds
Bye.
good. Bye.